Hello everyone, my name is Jennifer Leon Lycia. I'm a senior student at Kaiser University when I'm pursuing my doctorate program in nursing anesthesia. Before I tell you about my project, I would like to tell you about a patient that I had during my first anesthesia clinical rotation. I cared for this patient who had undergone an orthopedic surgery a few months earlier. As we completed his pre-op assessment for another surgery that he was coming to, he shared something that caught my attention. Despite receiving a peripheral nerve block during his previous procedure, he told me that he had experienced significant postoperative pain later that same day. As a new CRNA, I remember thinking, wasn't the block supposed to last much longer? When we review his previous anesthetic record, the anesthesiologist discussed modifying the original anesthesia plan based on this patient's prior experience. After the procedure, the patient reported much better pain control and a more comfortable recovery than he had experienced before. That moment stayed with me. It made me realize that regional anesthesia is not simply about performing a technically successful nerve block. It is also about asking whether we are optimizing the block to provide the best possible postoperative analgesia. From that experience, I began asking myself one simple question. How can we make peripheral nerve block last longer while providing better postoperative pain control for our patients? That question, ultimately, became the foundation of my doctoral capstone. My project is titled Synergistic Application of Dexmedetomidine and Dexamethasone in Regional Anesthesia, Implications for CRNA Practice, Educational Analysis. Postoperative pain continues to be a significant challenge in surgical care. Regional anesthesia has demonstrated superior analgesic efficacy compared with intravenous analgesia while preceding fewer side effects, and peripheral nerve blocks have become an important component of multimodal analgesia. However, there's an important limitation. The analgesic duration of a single shot peripheral nerve blocks remains limited by the pharmacokinetics of the local anesthetics itself. Once the local anesthetics effects begin to resolve, postoperative pain may return. This limitation has increased interest in the use of adjunctives that may extend the analgesic duration and improve block quality. Among the available adjunctives, dexamethasone and dexmedetomidine have received considerable attention. Dexamethasone has an anti-inflammatory effect, reduces perineal edema, and may prolong nerve block duration through the membrane stabilizing properties. And dexmedetomidine is an alpha-2 adrenergic receptor agonist that's activating descendant inhibitory pathways and modulates nociceptor transmission at the dorsal horn. Both agents have independently been shown to prolong peripheral nerve block duration compared with local anesthetic alone. The question becomes more interesting when the two medications are combined together. The literature suggests that dexamethasone and dexmedetomidine, what I refer to throughout my entire project as Dex, may have complementary effects. However, despite positive results, the evidence is not completely uniform. There are some differences in dosing strategies, administration routes, block types, studies designs, and outcomes measures. The literature also remains unclear as where the interaction between the two medications is primarily addictive, synergistic, or possibly an antagonist in some circumstances. So although Dex is promising, there's still uncertainty regarding its consistent clinical application. The clinical education gap, and this is where really my capstone developed beyond the question of whether two medications can prolong the nerve block or not. My manuscript identified an important educational and implementation gap. Despite increasing evidence supporting Dex in regional anesthesia, standardized educational resources and clinical guidance remain limited. The lack of understanding can contribute to the difference in provided knowledge, dosing, and clinical application. For anesthesia students, this is especially relevant. Understanding the Dex combination requires the learner to integrate pharmacologic mechanism, clinical efficacy, dosing considerations, route of administration, adverse effects, block type, and, most importantly, patient-specific factors. The literature in my manuscript emphasizes that the differences in pharmacologic knowledge and in demanding of perioperative environment may create risk to patient safety and clinical efficacy. For nurse anesthesia students, the variability within the literature may also increase cognitive burden and could make it more difficult to synthesize the evidence and apply it consistently in practice. So the problem I identified was to unfold. We have an emerging pharmacological strategy with a promising clinical outcomes, but we also have variability in the evidence and the lack of a standardized education to help providers interpret it and apply it. The purpose of my project was to critically evaluate the current evidence surrounding the combined use of dexmedetomidine and dexamethasone as adjuncts in the peripheral nerve block and facial plane blocks, and then translate the evidence into an educational research for nurse anesthesia practice. More specifically, I examined the pharmacological mechanism of dex-a-dex, analgesic direction, postoperative pain scores, opioid consumption, dosing strategies, and reported adverse events. I also saw the development on an evidence-based educational module using the cognitive load theory and gate control theory, and to propose an evidence-informed clinical framework that could support a safer and a more consistent institution-specific implementation. The broader aim was therefore not simply to summarize the literature. It was to take a complex and sometimes inconsistent evidence and organize it in a way that it could improve knowledge retention, clinical reasoning, and the application of the evidence-based regional anesthesia among DNMPA nurse anesthesia students. Now let's talk about the project methodology. To examine the evidence, I used an integrative literature review approach. The literature search included PubMed and CINAHL throughout EBSCO host. The search period was 2016 through 2026. The search included terms related to Precedex and Decadron, Dex-a-Dex, peripheral nerve blocks, fascial plane block, regional anesthesia, adjunctives, analgesic duration, opioid use, and postoperative pain. Titles and abstracts were initially screened accordingly to the predefined inclusion and exclusion criteria, followed by a full text review and potentially eligible studies. The study selection process was documented using a PRISMA framework. The evidence was evaluated using a grade approach, which considers factors including risk of bias, inconsistency, indirectness, imperfection, and publication bias. The studies were compared accordingly to the outcomes most relevant to this project: block duration, postoperative pain scores, dose ranges, opioid use, and adverse events, block types, patient outcomes, and dose regimens. Ultimately, the evidence profile included 6 peer-reviewed studies involving a total of 298 patients. This consisted of 3 randomized controlled trials, 1 retrospective cohort study, and 2 CARES reports. Most of the included studies evaluated combined dexmedetomidine and dexamethasone administered either perineally or intravenously. Now let's talk about results. Analgesic duration. When I synthesized the findings, one of the clearest patterns was prolongation of analgesic duration. One randomized controlled trial evaluated rhomboid intercostal and subserratus block in patients undergoing thoracoscopic surgery. With ropivacaine alone, analgesia lasted approximately 154.5 minutes. When dexamethasone or Decadron was added to ropivacaine, duration increased to approximately 282 minutes. But in the Dex-a-Dex group, analgesia lasted approximately 1,073.5 minutes. Another study involving foot and ankle surgery demonstrated a similar pattern. Median block duration was 870 minutes in the placebo group, 1,400 minutes in the dexamethasone group, and 1,572 minutes in the Dex-a-Dex group. These values are shown directly in the results section of my poster because they provide a clear visual representation of the magnitude of the difference reported in these studies. The findings cannot be generalized into one universal regimen because the studies differentiate in blood type and dosing strategy, but the direction of the findings was consistently favorable towards prolonged analgesia. Now let's talk about opioid consumption. The second most important outcome was postoperative opioid consumption. In the retrospective study included in the review, patients receiving Dexadex required an average of 108.22 morphine milligrams equivalents, compared with 275.63 morphine milligrams equivalent in the ropivacaine control group. Another randomized trial reported significantly lower morphine consumption at both 28 and 48 hours when dexamethasone and dexmedetomidine were combined compared with dexamethasone alone. A separate trial also demonstrated reduced oxycodone requirements during the first 24 hours compared with the ropivacaine alone. Across the evidence review, the combination was therefore associated with a lower postoperative opioid requirements. For nurse anesthesia practice, this finding is especially relevant because it supports continuous evaluation of Dexadex as part of multimodal perioperative pain management strategies. The third outcome involved postoperative pain scores. Several of the other review studies demonstrated improvements in pain score with the combined regimen. My manuscript also reports one study in which postoperative lower extremity pain was significantly reduced with a numeral rating scale score of a 2.32 after the operation compared with 8.58 on postoperative day 1. In addition, one trial demonstrated a significantly lower incidence of nausea during the first 48 hours compared with dexamethasone alone. Regarding safety, the review studies did not demonstrate a consistent increase in serious adverse events. However, this point has to be interpreted cautiously. The evidence base is too small to establish definitive conclusions regarding the long-term safety. For that reason, my poster intentionally describes the safety findings as a short-term safety, rather than concluding the combination is universally safe. Now let's interpret these results. When the findings are combined together, a consistent patterns emerge. The Dexa-Dex combination was associated with longer analgesia duration, lower postoperative pain scores, and the reduction of opioid requirements across the studies included in the review. But a doctoral interpretation requires us to consider not only what the studies demonstrated, but also the limitations of the evidence. The number of the studies remain limited. Studies designs differ, dosing method differed, routes of administration differed, and blood types differed. Outcome measurements were not completely consistent, and 2 of the 6 studies were case report, which provide a valuable clinical observation but represents a lower quality evidence than randomized controlled trials. These limitations are important because they prevent the current evidence from supporting one universal dosing strategies or one universal approach to Dexa-Dex. That is why the conclusion of my project is deliberately cautious. The evidence is promising, but variability in dosing, method of administrations, blood types, and limited long-term safety data mean that the approach cannot be yet to be universally recommended. Now let's talk about some clinical implications for CRNA practice. The clinical implications of this project extend beyond simply prolonging a nerve block. The first implication is evidence-based analgesia. Dexa-Dex represents a promising adjunctive strategies associated with prolonged analgesia, improved pain control, and reduced postoperative opioid requirements. The second is a clinical decision-making. CRNAs must evaluate adjunctive selections according to the patient's factors, the type of block pain being performed, administration routes, dose evidence, and institutional policy and safety consideration. The third implication is education. A structured educational module may strengthen pharmacological knowledge, clinical reasoning, and the translation of emerging regional anesthesia evidence into practice. The fourth implication is a practice standardization, institution-specific guidance addressing the adjunctive selections, dosing considerations, Documentation and the monitoring may reduce variability in practice and support safer implementation. And finally, the reduction in opioid requirements reported throughout the evidence supports continued evaluation of data DEX within multimodal preoperative pain management strategies. This is where the educational component of my project becomes particularly important. Rather than simply telling students that combination appears effective, the educational framework is designed to help future CRNAs understand why medications may work together, what the evidence actually demonstrates, and whether there's evidence remains uncertain, and how these limitations should influence clinical decision making. Future research. My review also identifies several priorities for the future research. Larger multicenter randomized controlled trials are needed to strengthen the quality of the evidence. Research should establish standardized dosing recommendations for different peripheral nerve blocks and fascial plane blocks. Perineural and intravenous administration should be directly compared to determine the most effectively route. Long-term safety outcomes and potential adverse effects associated with repeated DEX use require further evaluation. The combination should also be compared with the commonly used regional anesthesia adjuncts to determine relatively efficacy. Finally, future research should evaluate whether the standardized educational modules and clinical protocols actually improve knowledge retention, clinical reasoning, and evidence-based practice among anesthesia providers. To conclude, I would like to return to the patient I introduced at the beginning. At that point in my anesthesia training, I did not yet understood all of the mechanisms, evidence, limitation, or unanswered questions around the regional anesthesia advantage. What I understood was much simpler. I saw a patient who remembered being in pain, and I saw how important postoperative pain control was to his experience. That clinical encounter created a question for me, and this capstone allowed me to examine the question through the evidence. The literature I reviewed suggests that combining dexmedetomidine and dexamethasone may prolong analgesia, reducing postoperative opioid requirements and improving pain control when used in advantage in peripheral nerve block and fascial plane blocks. At the same time, the current evidence contains important limitations, including heterogeneous studies designs, variable dosing protocols, different administration routes, and limited long-term safety data. For that reason, cautious implementation and continued investigation remain necessary. The distribution and contribution of my project is therefore not to propose a DEX as a universal answer. It is, on the other hand, to take emergent evidence and translate it into a structural educational framework that can strengthen the knowledge, the clinical reasoning, and the evidence-based decision-making in nurse anesthesia practice. Ultimately, this project began with one of the patients that created a question for me. How can we provide longer-lasting and more effective postoperative analgesia for our patients? The evidence suggests that DEX may be one of the promising part of that answer. But equally important, it is ensuring that CRNAs understands the evidence well enough to determine when and how emerging strategies can be integrated safely into the practice. Thank you so much for your time, and I hope this topic might be of your interest.